Hello friends, let us learn about the evaluation of pituitary, that is cellular mass lesions. So in our last class we have learned about pituitary adenomas, craniopharyngiomas, and then cellular chondromas, meningioma, histiocytosis X, pituitary metastasis, hypothalamic gliomas, brain germ cell tumors. So now let us learn how to evaluate these pituitary tumors. All these pituitary tumors or cellular lesions will have mass effects, local mass effects. This is because the dorsal cellular diaphragm which is there, that will have the least resistance. So because of the least resistance of dorsal cellular diaphragm, the adenomas normally extend in supracellular direction. So they extend above. So this is the cellular and this is the dorsal diaphragm. This dorsal diaphragm, because of least resistance, there is extension of this tumor to the upwards because of least resistance. So they extend into the supracellular region. This is supracellular. This is cella turcica. Okay. So this is what generally happens. Now, the most common feature of this, first, whenever there is small intracellular lesions, these intracellular tumors mostly present with headache. Okay. Why headache? Because these intracellular tumors will stretch intracellular pressure. Due to the intracellular tumor, it will stretch the dural plate, thus causing headache. Intracellular tumors, intracellular pressure stretches the dural plate, leading to headaches. Whenever there is supracellular extension, this supracellular extension, it causes, number one, compression of optic chiasma. Whenever there is compression of optic chiasma, it leads to visual loss, and then it will invade the optic nerves directly. This will lead to secondary visual disturbances. And then this will supracellular extension. This will also cause the compression of the pituitary stalk. Whenever there is compression of the pituitary stalk, this will disrupt the pituitary access to the hypothalamic hormones and also dopamine. So hypothalamic hormones like prolactin and the vasopressin, hypothalamic hormones like prolactin and vasopressin, which are produced in the hypothalamus, and also the dopamine, these are not transferred from hypothalamus to the pituitary because of the stalk disruption. This results in hyperprolactinemia. It causes hyperprolactinemia. The hypothalamic hormones are oxytocin and vasopressin. Oxytocin and vasopressin, which are hypothalamic hormones, they cannot pass from the hypothalamus to the pituitary, thus causing hyperprolactinemia. And also there is decreased ADH and decreased oxytocin. The reason why there is decreased ADH and oxytocin is due to disruption of pituitary access to hypothalamus. And why there is hyperprolactinemia is dopamine normally will inhibit prolactin secretion. But here this inhibition by the dopamine is not there. And that is the reason why there is hyperprolactinemia. and this is seen whenever this stalk is involved. And then there is also a phenomenon called as stalk section phenomenon. This stalk section phenomenon is caused whenever there is trauma and whiplash injury with posterior clinoid stalk, which is compressing with posterior clinoid stalk compression or skull base fractures. So because of these fractures and stuff, the pituitary stalk is cut off. So because of that, even in that situation, you see hyperprolactinemia and decreased antidiuretic hormone and oxytocin. Then sometimes there is lateral mass invasion. Whenever there is lateral invasion, so lateral invasion, it can invade to cavernous sinus. So whenever it invades to cavernous sinus, it mainly compresses the neural tissue which is present, and this leads to the third, fourth, sixth nerve palsies, plus also fifth nerve, ophthalmic and maxillary branches effects, palsies. So this includes diplopia, ptosis, ophthalmoplegia, and decreased facial sensation. So these occurs whenever the fifth nerve is involved. So this is what is seen whenever the cavernous lobe is involved in lateral invasion. Then whenever there is extension to sphenoid sinus, this can be mainly due to the erosion of pituitary mass through the cellular floor. Whenever there is erosion of pituitary mass through the cellular floor, that causes extension to the sphenoid sinus. Okay, whenever there is involvement of temporal or frontal lobe involvement, in such cases it causes uncinate seizures due to temporal lobe and due to frontal lobe. This is due to temporal lobe and due to frontal lobe. It causes anosmia and also personality disorder. That is personality disorder. These both are due to the frontal lobe. These are seen. And then you will I'm really sorry for this. And then these are seen whenever the mass extends into the temporal and frontal lobe. And then if it extends into hypothalamus and compresses the hypothalamus, it causes temperature dysregulation, because hypothalamus is one of the important part in temperature maintenance, and it can also cause appetite and thirst disorders. Next, it can cause obesity and diabetes insipidus, sleep because of decreased ADH, and sleep disturbances or disorders are seen, and it can cause behavioral dysfunction and autonomic dysfunction can be seen. Okay, if it is involves pituitary, only pituitary, it causes hypogonadism and also hypothyroidism, and then growth failure because of decreased growth hormone, and in adult it causes hyposomatism, somatotrophism, and it can cause hypoadrenalism. So these are the different clinical features that you see in cellular lesions. Now let us learn about the MRI. MRI you can do sagittal and coronal T1 weight MRI is done. So here it shows the visualization of pituitary gland with clear delineation of hypothalamus, pituitary stalk, and pituitary tissue, and you can also see supracellular cisterns and cavernous sinuses can be seen to know the extension. Sphenoid sinus is also seen for extension, and also optic chiasma are seen. Okay, these are seen in sagittal and coronal T1 weighted MRI with gadolinium contrast. Okay. Next, if you take CT scan will clearly define the bony erosion and calcification. So in adenoma, you can see heterogeneous consistency of pituitary. In T1 weight imaging, and then you also see because of high phospholipid content we can see pituitary bright spot. This is homogeneous consistency. I'm sorry, this is not heterogeneous. You can see homogeneous consistency of pituitary in T1 weight, and in T2, this is seen in T2 weight. In T2 weight, you can see high phospholipid, because of high phospholipid content, it shows as pituitary bright spot in T2 weight imaging. So this is one thing which is seen. These cellular masses are mostly encountered as incidental findings on MRI. So these are incidentalomas. Okay, so how do you treat them? You will have to safely monitor it. Monitor the lesion. There is no need to resection. Monitor the lesion. Resection is done if they are macroadenomas. If they are macroadenomas, then you will have to resect it. Why should you resect it if they are macroadenomas? As 1/3 of macroadenomas are locally invasive. and because they are large, they cause pressure effects. So you will have to resect them. So if if you find meningiomas, these meningiomas are often associated with bony hyperostosis. Craniopharyngiomas, these craniopharyngiomas are calcified and usually hypodense. And then gliomas, these are hyperdense on T2 weight imaging. Okay, so these are the different types of different things which you have to see on MRI. Then ophthalmologic evaluation, you have to even do eye examination. Why? Because you have seen that optic chiasma is being compressed by this. So you will have to use perimetry. On perimetry you can see bitemporal hemianopia, or sometimes you can also see superior bitemporal defects can be found. And then sometimes there may be loss of red perception. It can be due to a sign of optic tract pressure. So this is important, loss of red perception. And what are the laboratory investigations that you have to do? The lab tests include to know the nature of tumor and the presence of hypopituitarism. So here you will have to do 5 main tests. So here the first you have to do initial hormonal evaluation. In them you will have to do number 1, basal prolactin for prolactinoma, and then you will have to do insulin like growth factor 1 for growth hormone. This is for prolactin. Okay, and then third you will have to do 24-hour urinary cortisol and or overnight oral dexamethasone. So this test is done for adenocorticotrophic hormone. And the fourth one is alpha subunit of FSH. Alpha subunit FSH and LH are assessed for FSH and LH levels. And then fifth one you will have to do thyroid function tests for TSH. So these should be done, and you should also assess the menstrual history to know the gonadal functions, and then you will have to measure testosterone and 8 AM cortisol levels for additional information. Histological evaluation. Histologic evaluation, for this you will have to do a immunohistochemical training, histochemical staining of pituitary gland, of pituitary tumor, specimen, and it is done after doing transpenoidal resection. After resecting the tumor, you do this immunohistochemistry. Okay, and then you can examine under microscope also, that is electron microscope also. And how do you treat these masses? Cellular masses, all the cellular masses, maybe hypothalamic, pituitary, or which have extracellular extension. How are you going to treat it? So we have done MRI gadolinium contrast, and we have found out the major pituitary tumor, where it is, and then the major goals of treatment include: 1, normalize the excess pituitary secretion. It should be normalized, and you should decrease the symptoms, amelioration of symptoms. All the symptoms and signs should be decreased, basically of those of hypersecretin syndromes, because these causes many adverse effects. So all these should be decreased, and you will have to shrink or ablate large tumors, because large tumors can cause compression, so you'll have to relieve the compression. It will cause relief to the compression. So all these three are the major goals of the therapy. So first, surgery is the best stay. In them you can do transpenoidal surgery. So here, through the transpenoidal route, you approach the thing, and then you can also do intraoperative. In the middle of the operation, you can do microscopic evaluation. So this will distinguish between adenomatous and normal pituitary tissue. And once you have distinguished the adenomatous and normal pituitary tissue, and then you can also do micro dissection of the pituitary tumor. Micro dissection of the small tumor can be done. Okay. Advantage of this transpenoidal route is it avoids the cranial invasion, and also the manipulation of the brain tissues, because brain tissues are very important, and even one cell is also very useful. So the brain tissue manipulation is avoided, and cranial invasion is also avoided. So that is the first important thing in this. So it will correct the hypersecretion, and even mass lesions can also be corrected. Once the mass is removed, then the hypersecretion is obviously corrected. So how do you approach transpenoidally? I think you have understood what transpenoidally is, but I would like to just draw a diagram for those who did not understand. Okay, so this is the nose. This is the inside of the nose, and this is the palate, and this is the part of the palate which is here, and then this is the sinus, and this is the one. So this is the sphenoidal sinus. Okay, and you see it like this, and here you see the pituitary stack, pituitary and pituitary stack, and this is the frontal sinus. Now you have two routes. One is to the transfrontal, and the other is through the transpenoidal. This is transfrontal, which is done some years back. It is not used now, because here you will have to manipulate the bone tissues, manipulate the brain tissues. So because this may cause damage to the brain tissues, so this is not generally used. We generally use transsphenoidal route. Okay, here we'll resect as much as pituitary tumor is possible. We will resect pituitary mass selectively, but if we have to do for effective mass dissection, we will have to dissect the normal pituitary tissue for is manipulated. We'll have to manipulate even the normal tissue in some cases. Okay, so non-selective, that is called as non-selective hemi-hypophysectomy, where you will remove half of the pituitary gland, hypophysectomy, or you can do total hypophysectomy. This can be indicated if there is no hypersecreting mass lesion is seen clearly, because we don't know which mass is clearly secreting, and remaining tissue is necrotic. Remaining non-tumorous tissue has become necrotic. Then you do this, or else you will try to preserve the pituitary gland. After surgery, all the mass effects will be reversed in most of the cases. So mass effects are reversed, may be reversed after surgery. So the major thing is risk versus benefit ratio should be considered for extensive tumor resection. Okay, next, what are the side effects? The side effects are tumor size and degree of majorly the tumor size and the degree of invasiveness. This is the responsible for the side effects and also surgical complications. So the major surgical complications include permanent or transient diabetes insipidus, cranial nerve damage, and most importantly hypopituitarism, because we may remove the major part of the pituitary, so the patient may land up in hypopituitarism. There may be visual disturbances. As we are approaching through the nose, it can cause nasal septal perforation and sometimes sphenoidal sinus, and then we approach the brain, we approach the cranium, so it can cause CSF leak. And less common complications include, sometimes there can be carotid artery injury, then there can be loss of vision or hypothalamic damage can be seen, and sometimes you can see meningitis. Okay, so these are the major side effects that you see after the surgery. The next, after surgery, we can't just do the surgery and leave off because there may be recurrences. So the best thing is doing radiation. It can be done as a primary therapy or adjunct to surgery. First, we give a total of less than 50 gyri is given has 180 CGY, that is 180 radiations fractions divided over for about 6 weeks. We can do stereotactic radiosurgery. This stereotactic radiosurgery will deliver a large single high energy dose from different instruments. It can deliver from you can use cobalt 60 source, which is a gamma knife, or we can also use a linear accelerator, or cyclotron can be used. The major long-term side effects are unclear. The role of radiotherapy. It will depend on nature of tumor, age of patient, availability of surgical and radiation exposure expertise. So these are the things which are on which the role of radiotherapy on pituitary tumors, it is dependent on these conditions. Generally, we give this after surgery, as I have said. And then the major side effects of this radiation therapy are transient nausea, and then weakness, and then there can be alopecia, and then loss of taste, smell, are long lasting. The pituitary hormone synthesis the pituitary hormones cannot be synthesized in most of the cases after irradiation. So there can be hypopituitarism, either complete or partial. Then you will have to do a lifelong follow-up of the pituitary reserve should be done. Of pituitary hormone reserve should be done because of the danger of hypopituitarism. And then in some cases you should also do the side effect can be optic nerve damage can be seen. In some cases this can lead to optic neuritis and also impaired vision because of optic nerve damage. Sometimes you can also see cranial nerve damage is seen. And then these are the different side effects which are seen due to radiotherapy. Then medical therapy. Medical therapy, it is done mainly for the tumors of prolactin and growth hormone secreting tumors. For prolactinomas, you can give dopamine agonist. It is the treatment of choice. And for acromegaly, you can give somatostatin analogs, or you can also give growth hormone antagonists can be given. Then for TSH secreting tumors, even for them you can give somatostatin analogs can be given, and rarely, occasionally, sometimes you can also give dopamine agonists. So these are the medical treatment that is available for pituitary tumors. So thank you guys for watching my lecture. If you have any doubt, please comment it in the comment section. If you feel something is inadequate in this lecture, even then comment it in the comment section. In my next class, I will teach about the most important topic of prolactin, that is hyperprolactinemia. Thank you guys for watching my lecture. Please subscribe the channel for more videos. Thank you.